call me Cuba Pete. I'm the king of the rumba beat. When I play the maracas, I go chick, chicky, boom, chick, chicky, boom. Hey!
Hi, and welcome to another episode of Cuba Pete, No Laughing Matter. I'm Pedro Joe Greer. I'm the dean at Roseman University College of Medicine. And the idea of this program is to take things that are happening in society, how they influence people's health, and how they should influence us as we develop a new medical school with a new curriculum, and what needs to be taught to prepare this future workforce. So live from Studio A in Las Vegas, it's Cuba Pete, No Laughing Matter, and I'm joined here today by two incredible individuals, Dr. Farzad Kamyar and Quintella Winbush. He is a psychiatrist, and a very special psychiatrist, I might add. And Quinny is a peer support specialist. Mental illness in the United States of America is, in my opinion, the number one public health problem we have. One that we tend not to address appropriately. We don't even have a system that could take care of this situation in this country appropriately. We actually have very few systems in healthcare that do that. However, mental health is increasing. We see the number of suicides. 80% of gun deaths are suicides. 80%. They aren't big guns, they're little handheld guns. So we need to find policies to deal with that. The stress that children are being put through, what has happened during COVID. The fact that prior to COVID, we saw reports of increasing suicide, poisoning, or overdose, and alcoholic liver disease, interestingly not led by blacks or Hispanics, but led by non-Hispanic whites. And they actually in 2017, for the first time in 100 years, increased the morbidity and mortality of this country. And these individuals had one difference than those that were their same age. They were mostly boomers. They never went beyond high school. The social determinants. And I know that in drug rehabilitation or drug therapy, that the social determinants become one of the most important factors for recidivism in what happens in an individual. Let me start off with you, doctor. First of all, it's a pleasure. Now, I want you to know that this guy was a software engineer from San Diego State University. And we have to say, and I don't even know her name. What is your wife's name?
M.O.T.H.E.R.
Monica?
Yeah, but she goes by MJ.
Okay, MJ, thank you. Because as the story goes, when he met you in business school, you were the one that got him interested in going into medicine. Is that true?
It's true. Yeah.
It's true. Now they have two kids, two boys, 11 and 6, right?
Yeah.
You're lucky. I have two kids. My older one's a girl and my younger one's a boy. And when your older one's a girl, you think you dropped your son on his head, okay? So you're very lucky to have two boys. He is a psychiatrist and also certified in addiction medicine. But before we go into that, what drove you to go into psychiatry?
I think you touched on some of those points, right? So I was training during a time when I think mental health was still that unknown, not really hot topic, something highly stigmatized, and it just kind of wasn't being addressed. Generally in medical school and healthcare, you have a bunch of brilliant people who are wanting to help other people. And there was plenty of my colleagues who were going into all sorts of other fields, not so much the interest in mental health. And so effectively when I was looking at the impact that I could make, not only was it, well, not a lot of people are going into mental health, but then also what's that impact that I can have? And when you look at sort of chronic diseases that span other specialties, mental health impacts the family, the children, the friends, the social network, potentially more than, if I'm someone who has high blood pressure, no one in my family might even know. But if I'm someone in my family who has a substance use issue or bipolar, it's probably a good chance.
Well, I'm a gastroenterologist, and I would say 80% of my patients had an underlying behavioral health disorder, which was manifested in the GI tract.
There you go.
It could be anxiety, it could be depression, it could be bipolar, and things that we don't normally talk about at home. But you had something very special for you to look at something like that in medicine when nobody else was looking at it, because I also remember one of the other sad things about mental health, is doctors are afraid of it.
Yeah, absolutely.
And there's a lot of prejudice towards patients with mental health. They're not telling me the truth, this and that. So you went into an area nobody wanted to go into. Now it's the biggest health crisis in the country.
That's right.
And so we need to develop a national system. You'll have that next week. He is also the director of the Collaborative Care of the High Risk Pregnancy Center and co-creator with his partner in crime, Dr. Brian Erie, with the Maternal Opioid Treatment, Health, Education, Recovery, which stands for MOTHER.
Right, yes.
And what got you into that?
Yeah, so my wife, who's specializes in perinatology,
Okay.
is one of the physicians at High Risk Pregnancy Center, and just basically talking shop. A lot of issues of substance use was coming up. These are difficult patients. They're having really bad outcomes. Furthermore, the neonates and the infants were having really horrible outcomes. And
the what he's talking about is the little newborn babies and the problems they were having, apart from, I would think withdrawal would be a major one.
Major, right. And so, yeah, so directly it was related to basically dealing with the pregnant population, right? Discussing these cases. And one of the medications and treatment options that we have was primarily being used in the Valley, but it was one here in Las Vegas Valley. It's not one that I was specifically trained on versus a newer medication. And so I was like, well, why don't we just bring a program that uses some of these newer options, newer modalities, and see if we can improve outcomes for both, let's call it mom and baby.
There you go.
And so we started the MOTHER program.
Are you at a particular hospital or?
No, so it's outpatient based.
Okay.
It's outpatient based at our clinics that we have both in Southern Nevada and Northern Nevada.
And as a peer support specialist, you see a lot of these mothers.
Yes, every day. We have approximately about 10 patients right now at the Roseman University M.O.T.H.E.R Program, and probably about 75% of them are have mental health issues along with substance use. So I guess you call it dual diagnosis, something like that. I'm no doctor, but yeah.
That's exactly
so
right.
Okay. So yeah, and I see it a lot. And the thing is with me is that I'm not really afraid of it. And the reason is because, I have been around it, being that, I am in recovery, long-term recovery, and being out there in the way of the world that I was, using drugs, you run into that situation. Right. Not only that, my father was diagnosed as a paranoid schizophrenic at 24 years old. Wow. And that's from what I hear, that's the last stage. You're supposed to know before then, right? But anyway, yeah, and I have a lot of mental illness on my father's side. So not only is it mental illness on my father's side, there's also substance abuse. So it pretty much affects me.
Back in the late 80s, early 90s, I used to chair the Drug Policy Research Center at the RAND Corporation. And one of the things that we found was recovery. First of all, this whole thing that this country has, a war on drugs, it's not going to win. Yeah. We've been having this war on drugs since forever. Right. What we need to do is get, reducing harm. Mm-hmm. How do we help people? And we know that even if you have recidivism, if you're in a treatment program, you're not using. So you're reducing harm right then and there.
Right.
And it becomes imperative that we do that. But when you're a pregnant mother that's an opioid abuser or a stimulant abuser, which is what M.O.T.H.E.R does with, and you are our psychiatrist. He's my psychiatrist. He tells me that I need help. And is that these are not stable homes they come from. And so, and having dealt with a similar population at our prior institution where we actually took care of kids of incarcerated parents, And there might be more than one kid in the family. There might be more than one father. There might be more than one mother. I mean, there's all these interactions that go together with there. And a lot of times, these are families that are struggling. And one of the things that we found was if you don't take care of the peripheral, the social determinants, and you don't have good family support, your chances of recidivism go up even higher. And if you're an addict, what do addicts do, having been that the best man at my wedding became an addict? You steal from family and friends. And when you have very little resources, generally it's just mom that's going to welcome you back.
Right.
And tell me how you deal with that with the families.
Well, with me, I had, first and foremost, you know, God is in my life. I was born and raised in church. So my mom and my family always supported me. They always prayed for me. They knew that sooner or later, they didn't know when, I didn't know when, you know, that one day that I would get it together, you know? So you really don't know. A person really doesn't know until till you feel it. Like, I didn't know, I knew I was, because I'm a fighter. So I continue to fight every time I fell down. I don't care how many times I went to jail, prison programs, continue to fight. When you get tired, a person only knows once they get tired. So like where we work at, with the M.O.T.H.E.R program, just like you were talking about how they're in a program so that reduces their use. But what about when you get out? That's where we come in, to be able to accommodate them, try to help them to get housing, help them to get Social Security, help them to get their ID, everything that they need in order to function in life. Because that's a whole nother part of it. You can stay in the program for a year. I went to 7 programs. It didn't really click until the last program. And that was over 11 years ago.
Congratulations.
You know, so it just depends. You know, it just depends. So that's where I think that it's really a good, M.O.T.H.E.R is such an awesome program, you know, with Dr. Farzad and, you know, with me and Rachel Mack, who is the program care manager, Rachel Williams, who's a therapist, and of course, Dr. Andrea Peterson. I feel that we are doing the women a big justice for being there because they have somebody that they can go to. We are their support. A lot of times we're their only support. They have nobody else but us. So I feel like I have a lot of gratitude for being there because I feel that everything that I went through in my life was for a reason and a purpose. It wasn't in vain, because now I'm able to reach back and help those that come through those walls at the M.O.T.H.E.R program and let them know that we care and we are support for them.
And that's the most important thing, is caring and
Yes.
support.
Yes.
100%. Doctor, what would you say is the most common underlying illness, a mental illness with substance abuse? I know that it could be depression causing you to use substances, or it could be another disorder where the drugs themselves are used as therapy.
Yeah, so if I had to pick a most common, it wouldn't be a formal, like, let's say DSM diagnosis of major depressive disorder or post-traumatic stress disorder. Probably experiencing trauma.
Experiencing trauma?
Yeah.
You know that they did a study at the Los Angeles Unified School System. 95% of the kids had either visualized or been part of trauma.
Yeah.
And so...
Yeah, there's something called the ACEs study. Are you familiar with ACEs? So ACE, Adverse Childhood Experience. Okay. Big study with the CDC. I think it was in partnership with Kaiser.
It was. Kaiser was the first one to look at it actually as causes of obesity.
Right. So thank you for mentioning that. Long story short, there's these definitions that they have for what are adverse experiences. Things like having a parent with mental health issues, incarceration, violence, you yourself experiencing neglect or abuse, et cetera, et cetera, et cetera. Then they looked at a bunch of outcomes. And the majority of the outcomes were negative, right? There was a negative connotation,
Right.
whether it's a chronic disease, whether it was a level of education, vocation, et cetera, et cetera. Basically what they found was the more adverse childhood experiences that you experienced, the worse off you were going to be. So much so, including these chronic diseases, adverse health outcomes, including heart disease, cancer. I mean, sort of you name it. One of the conclusions, or assumptions, was or conclusions, let's call it, that there's no single greater factor that contributes to these things than trauma and these adverse experiences.
And it's a sad thing for my profession that it's only pediatricians that ask those questions.
Right.
Actually, we had a guest here, and she started an organization that was for children of incarcerated parents. And she says what happens is, once you age out, there's no support for you. But then no doctor has ever asked about ACE. And her suggestion for the medical school was train your doctors so they ask that with every patient that goes through, which is so vitally important. And particularly even in my subspecialty, which was GI, and that's only because the gastrointestinal tract, which is actually 3 different organs joined together by embryologic development, it's only second to the central nervous system in innervation. So all these things are going to be affected somehow in your gut. Acid, constipation, loose stools, abdominal pain, and all the things that drive you to the doctor, that the doctor then says, okay, let's get a CAT scan and do an endoscopy. Yeah, and in the meantime, nobody asked a question. I'll tell you a funny story that happened to me one time. So I had a 30-year-old type A young Hispanic attorney come to me, convinced that she had colon cancer because her next door neighbor and best friend was just diagnosed with it. And so she had no indication whatsoever for a colonoscopy. So after 2 hours talking to her, I said, listen, come back when you turn 50 for your screening colonoscopy. We had a long, long discussion. I think almost like you would have with your patients. So she comes back 20 years later and says, do you remember me? I said, no, I'm sorry, I don't remember you. She goes, I was here 20 years ago. I said, oh, I hope you're doing okay. She goes, no, I followed your advice, I feel great. I said, really? I said, what was my advice? She goes, oh, I got a divorce. I said, I told you to get a divorce? No, you told me to get rid of my stress. So I said, wow, I got to phrase these things a little differently from now on. This is not quite my job to say something like that. What kind of training? Because I plan to put mental health questions with every single case that is presented to a student, as well as social determinants, as well as ethical conflicts, as well as disparities. So that if a patient is diagnosed with a mental health disorder, what is the actual disparity? What is that found? Now, there's a big problem in the studies too, looking at how we ask questions in an African American community versus a white community versus a Hispanic community as to classifying the patient with what illness they might have. Because most of our DSM, which is the classification of diseases, is based on a white population. And even within the white population, it's a taboo subject. Imagine an immigrant family. Imagine a family, an African American family. Imagine the families that don't get to have a good education, so they don't know what's going on. And they don't have access to medicine or doctors. So what would you do? I mean, one of my ulterior motives is to graduate as many psychiatrists as possible. We want to make it the dermatology of the present.
right. Yeah. What?
Besides the lectures you're going to give, I mean, but
okay, sure. Yeah, and questions like this come up with, let's call it specific to substance use, right? And targeting or introducing bias in sort of how do we figure out who and what and when and where and why. Universal. I'll just use the term universal. In substance use, we like to think of things like universal screening, but replace screening with whatever maybe that potential intervention is. But we're trying to identify things, right? Okay, so we might develop fancier tools in the future, but let's call it universal. So everyone. And this is important because we see, and the evidence shows this, right? When we're talking about substance use in general, we talk about overdoses, right? Which is like the pandemic of our times, and it was before COVID, it was overdoses, right? Drug overdoses. Number 1 cause of death for reproductive age women in the United States. Not cancer, not diabetes, not high blood pressure, not accidents. like motor vehicle accidents, et cetera, et cetera. Drug overdoses, right? Okay. So what we see is we have sort of a breakdown by race. You had mentioned Hispanic, Black, white or Caucasian, non-Hispanic population. When they looked at large sort of centers and who was being targeted for screening, right, which is sort of the first step in identifying, the majority of those were basically people of color. But when you look at the breakdown of who's actually using substances or has substance use disorder, it's the minority. So we were completely missing, right? We were underdiagnosing huge portion of the population and then overburdening basically another big portion of the population.
100%. There was a very interesting study that was done, my goodness, maybe 20 years ago, which looked at, if you looked at a Black, Hispanic, Asian, and white population who had the highest rates of drug use, and it was whites had it. The African Americans had one of the lowest, and then Hispanics were up. They are not quite as high as whites, and Asians in between Blacks and Hispanics. But we have this image in our mind that only the drug addicts are Black.
Correct.
But if you come from Florida, we had the pill mills.
Oh yeah.
Which it's an interesting point, and tell me what you think of this. I read an op-ed on this in one of our peer-reviewed journals, stating that the systemic racism in medicine is what prevented the opioid crisis from truly affecting the Black and brown community. Because when they would come into the emergency room, they would be looked as drug seekers. The white community really had pain.
Yeah, I silver lining, I guess, right? Silver lining from something that we normally tend to think of as being horrible, right? Horrible. Potentially, yeah, I mean, absolutely. So fantastic. Yeah. But now when we're thinking about treatment interventions, right? Yeah.
Not only that, because if you need in-house treatment, that means you're unemployed. And even if you have follow-up treatment, you could be employed, but you're going to have to take off. So you need really good family support. And if you have children, just the facts that you gave us right now about ACE, with these kids, you're not going to want to see your children go through that. What percentage of the American population do you feel has a mental health disorder?
Ooh, wow.
Excluding Washington.
Excluding Washington.
Because there you'd be at 100%.
Yeah. The numbers, so 2020 still being compiled from like the CDC standpoint and whatnot, right? We've got numbers of overdoses and those with substance use issues, which last time I checked was 40 million, which is roughly 15. But that's substance use. 15%.
And it's also how we collect the data. Most of this is hospital data, number one. Number two, right. And I remember when we were looking at this 30 years ago, when they were looking at things like, percentage of patients that tested positive for cocaine in the emergency room. Well, they forget the part that the doctor has the discretion to order the test or not. So you could have had a lot of people doing drugs that you just completely missed.
Right. Yeah. I would say probably at best a quarter of the population.
Quarter. I would say you're being extremely conservative.
Right.
I really believe it is the number one public health problem we have in this country, because it not only is the public health problem of the mental illness, but one of the things that we found out in some of the case studies that we had done looking at social determinants was overutilizers of EDs. Unless you deal with the social determinant, you can't deal with the mental health issue. Mm-hmm. And if you can't deal with the mental health issue, you can't deal with the physical health issue. Mm-hmm. They're not going to take care of themselves and all these different things. So it's a matter that we can no longer live in the isolation of my specialty. I don't take care of livers. I take care of a human being that has a liver, that is surrounded by family and friends, that might have a substance abuse problem, alcohol, or, intravenously, then you're looking at different viruses and things of that nature. But all of these things contribute. And one of the problems with liver disease is what we call fatty liver, which a fatty liver looks exactly the same as an alcoholic liver. So if you have an alcoholic that's not taking care of themselves, and they had, especially in the insulin resistance, they're going to develop cirrhosis, which is the third leading cause of death in the population of death deaths of despair. What would your solution be? Where do we start identifying? Pre-K?
Why not? Why not? Yeah. I think making it a comfortable conversation or a comfortable topic, leaving hopefully, ideally, the world of stigma behind when it comes to mental health. I mean, we have a long way to go.
Well, even in our own profession,
We have a long way to go. Yeah, exactly.
we don't talk about it.
Yeah. I think it would be great if people would feel comfortable sort of reaching out for help if it was on par with other chronic diseases.
You have to make it a conversation that people are comfortable with.
Yeah.
And we saw that within our prior institution, the medical school, was how do we get students to start, because there was an enormous amount of depression, and especially in residents, suicides, and doctors. How do we get the student comfortable with it? Because the student comes into medical school like a military. It's a very macho profession. You don't show emotion. So you don't want to be looked at as quote unquote weak. So we have to get rid of that. How do we get rid of these stigmas? That's number one. You're not looked at weak as if you have hypertension. So the first thing was just getting them to converse about suicide and depression and talk about that. And then having the available therapists if they need to see somebody. And that therapist cannot be on your faculty. Right. There's an inherent conflict in that.
Yeah.
So let's start screening. I mean, we just now, I think 2012 was the last time for signs of autism from birth. They just redid all the criterias. Why aren't we doing the same kind of criteria for people at risk for mental health or for substance abuse?
Mm-hmm. Yeah. I forget exactly what this sort of, cliched saying is, but if you don't ask, then you don't, right? On one hand, I wish that we could be really good at screening and get everyone plugged in, but I think if we were able to identify everyone who had an issue, the system would come crashing down.
Well, we have a workforce issue,
right,
and we have a systemic issue. We don't have a system to be able to do this. So, however we create that, this has to be done. I mean, that it's imperative. You have to be able to bring in your experiences, your experiences, and educate the students. Remember, the overwhelming majority of medical students, actually 79% of American medical students come from families that are in the top 2 quintiles of income. The average family income of a medical student is 2 to 3 times that of the national average. So if you think there's no stress in these families, there was a recent report came out where they were looking at mental health issues in public schools and they went to private schools. And they found that they were higher in private schools. And the reason is multifold, but one of them was the pressure the kids were getting from day one. What college are you going to? Let a kid be a kid, for goodness sakes. Really. I mean, I was like a senior in high school and I couldn't figure out what college I was going to. So I have matured a little bit since then. But is there anything that you would offer that we need to teach in medical school?
No, not at this time.
No.
I all I can give is my, my lived experience.
Well, that's something that maybe the students should be exposed to.
Yeah, and so they can be aware. Maybe talk about coping skills and being aware of your surroundings and who you're with and who you're running with, to try to put the awareness up more. I think that a lot of that was not around. Well, I know it wasn't. None of this help that is available now was available when I was drinking and using.
And the help that's around is not quite enough.
No, it's not. But it's here. And like you're doing now, you're bringing awareness about, what needs to be done. So that's a big thing. Back then, mental health or addiction was something that you kept behind doors. They don't want to talk about it.
That's exactly right. Mm-hmm. Even within the family.
Right.
Well, there's a lot we need to do in this country. One of them is admit to the problems that we have, then develop a system of not only mitigating it, but preparing the future workforce to be able to prevent it from happening again. We've too many times repeated this in our country's history, and it's time that we change that. So let's make this new medical school the medical school of the future. Let's make Las Vegas the place that people come here and we tell them things. We don't keep it in Vegas. That because we're from here, we see these problems, and you have these incredible individuals that are out there serving human beings. And in your case, thank MJ, okay?
Will do.
Okay, because if not, you would have been like a software engineer that owned a big company, and you would have no stress. But just with that,
Yeah.
Dr. Kamyar, Quinny, thank you both.
Thank you for
Your
having
contribution that you've made here, I think, is invaluable. And from Studio A in Las Vegas, it's goodbye for now.
They call me Cuba Pete. I'm the king of the rumba beat. When I play the maracas, I go chick, chiggy, boom, chick, chiggy, boom.